Lesion of the sciatic nerve and its branches. The sciatic nerve is the largest nerve in the body. The sciatic nerve starts from the nerve roots in the lower back, and the nerve roots join each other to form the sciatic nerve. It arises from L4, L5, S1, S2, and S3. It has two main components, the tibial nerve and the common peroneal nerve. The sciatic nerve runs through the buttock and the lower limb. The level of the division of the nerve is variable, but it usually occurs at the middle or the lower third of the thigh. In about 10% of the patients, the division of the sciatic nerve can occur at the greater sciatic foramen. Lumbosacral plexus injury can occur from a pelvic fracture with displacement of the sacroiliac joint. As the nerve enters the pelvis through the greater sciatic notch, the nerve passes underneath the piriformis muscle. That is the normal relationship between the sciatic nerve and the piriformis. There are some uncommon variations in the relationship between the sciatic nerve and the piriformis. However, the normal relationship with the sciatic nerve is the sciatic nerve passes underneath or anterior to the piriformis muscle. Entrapment of the sciatic nerve at the piriformis level is called piriformis syndrome. So what is piriformis syndrome? It is a condition of leg pain or sciatica due to compression of the sciatic nerve at the hip. So the sciatic nerve is irritated, not from a spine problem, but from problems related to and associated with the piriformis muscle. Clearly, the piriformis syndrome can be confused with sciatica and lower back pain. There are several tests commonly used to diagnose piriformis syndrome. The Lesions maneuver, which attests stretching in the nerve, and the Fair test, which is stretching the piriformis muscle itself. The Lesions maneuver, reproduction of the pain by the hip being flexed to 90 degrees and the knee extended. The test can also be done with the patient on the side. The other test, the Fair test. Fair test is not Faber test. Faber test is used to diagnose sacroiliac joint problems. Fair test is a piriformis syndrome test. So we're going to assess if stretching of the muscle is causing pressure on the sciatic nerve and patient symptoms. How do you do the stretching of the piriformis muscle? You do that by flexing, adducting, and internally rotating the hip. This maneuver will stretch the piriformis muscle and will cause symptoms because it will compress the sciatic nerve. It will put tension on the piriformis muscle and it will reproduce the symptoms of the patient. Also, during these maneuvers or these tests, when the examiner adds pressure on the posterior part of the buttock, the patient will complain of severe tenderness and pain. Piriformis syndrome is a diagnosis of exclusion. If the patient has symptoms of sciatica, then there must be an MRI of the spine that is negative for a disc herniation to prove that the symptoms are not coming from a possible disc problem. From the gluteal region, where the sciatic nerve is covered by the gluteus maximus, the nerve runs downwards to the back of the thigh. The sciatic nerve lies between the greater trochanter and the ischium, and as it descends anterior to the piriformis muscle, it crosses posterior to the tendon of the gemelli muscles, the obturator internus, and the quadratus femoris muscle. So the sciatic nerve is anterior to the piriformis, but posterior to the obturator internus. The sciatic nerve is close to the acetabulum. That's why it can be injured easily as the hip dislocates. The common perineal division of the sciatic nerve is the one that most commonly injured during dislocation or fracture dislocation of the hip. Injury to the sciatic nerve will cause foot drop. The sciatic nerve can be injured due to posterior surgical approach or errors in placement of the retractors, or because of lengthening of the femur, or from total hip acetabular screw placement. During posterior approach of the hip, if you need traction on the lower extremity, please keep the knee flexed and the hip extended during traction to avoid injury to the sciatic nerve. This is particularly important during posterior approaches to the hip and during posterior exposure and fixation of acetabular fractures. Total hip acetabular screw placement. If you insert acetabular screws in the posterior inferior quadrant and the screws are long, you can injure the sciatic nerve. The tibial nerve is the medial nerve and it descends down vertically towards the tibia. The common perineal nerve is the lateral nerve, it's the fibular nerve. High in the thigh before the nerve divides, the sciatic nerve supplies the hamstring muscles, which are the long head of the biceps femoris, the semimembranosus, the semitendinosus, in addition to the ischial part of the adductor magnus muscle. All these branches will come from the medial side of the sciatic nerve. The short head of the biceps femoris is innervated by the common perineal nerve. In the back of the thigh and just above the knee, the sciatic nerve divides into two nerves, the tibial and the common perineal nerves, which innervate different parts of the lower leg. The common perineal nerve then travels anteriorly around the fibular neck and it divides into superficial and deep perineal nerves. If you have an injury to the common perineal nerve, this will cause problems for both the superficial and deep perineal nerves. Injury to the knee dislocation. In cases of knee dislocation, it's important to check for common perineal nerve function and rule out popliteal artery injury. The common perineal nerve can be entrapped around the neck of the fibula. The superficial perineal nerve, which supplies the muscles of the lateral aspect of the leg, the peroneus longus and the peroneus brevis. In the distal third of the leg, the superficial perineal nerve then pierces the fascia to become superficial. At this level, the superficial perineal nerve can be seen through the skin. In the ankle, the superficial peroneal nerve divides into intermediate dorsal cutaneous and medial dorsal cutaneous branches that supply the skin of the dorsum of the foot. What are the lesions of the superficial peroneal nerve? The superficial peroneal nerve may become injured during fasciotomy of the lateral compartment of the leg. The lateral incision is usually made halfway between the tibia and the fibula for release of the anterior and lateral compartments. Here you can see we released the anterior compartment, and then after that we released the lateral compartment. Be aware that there is a nerve there. The nerve will be injured during release of this lateral compartment. Try to see that nerve and try to avoid it. This nerve can also be injured during anterolateral extensile approach that is used for treatment of pilon fractures. In chronic exertional compartment syndrome, look for fascial hernias. In asymptomatic people, only 5% has these fascial defects and hernias. But in people with exertional compartment syndrome, 40% has that fascial defect and muscle hernias. And the most common location is the distal leg, near the intermuscular septum of the anterior and lateral compartment. And that's where the superficial peroneal nerve lies and then exits. In these patients, you do not want to close the defect. You want to release the compartment so the muscle does not herniate and compress the superficial peroneal nerve. The superficial peroneal nerve can be injured during ankle arthroscopy. Care should be taken during establishing the lateral portal of ankle arthroscopy. It is very close to the superficial peroneal nerve. The other branch is the deep peroneal nerve. The deep peroneal nerve pierces the intermuscular septum and supplies the muscles of the anterior compartment of the leg, the tibialis anterior, the extensor digitorum longus, the extensor hallucis longus. It also gives innervation to the peroneus tertius and to the extensor digitorum brevis on the top of the foot. The deep peroneal nerve gives a sensory branch to the first web space between the first and the second toes. This is an important area for diagnosing problems with the deep peroneal nerve or diagnosing compartment syndrome that affects the anterior compartment of the leg. Injury to the deep peroneal nerve will cause foot drop. Anterior tarsal tunnel syndrome is a compression neuropathy of the deep peroneal nerve. The compression occurs within a fibroosseous tunnel formed by the inferior extensor retinaculum. There is some dorsal osteophytes over the talonavicular joint that are implicated in causing this compression neuropathy. The patient will complain of dull ache and vague pain, numbness and paresthesia in the dorsum of the foot, which radiates to the first web space. The condition gets worse with tight shoes and with plantar flexion of the foot. Now let's talk about the tibial nerve. The tibial nerve passes into the foot running posterior to the medial malleolus and beneath the flexor retinaculum. At this level, the posterior tibial nerve divides into medial and lateral plantar branches and medial calcaneal branch. So what is the tarsal tunnel? The tarsal tunnel is a fibroosseous tunnel posterior and inferior to the medial malleolus. The tunnel is covered by the flexor retinaculum, which protects the structures contained within the tunnel. The flexor retinaculum is a thick ligament that runs between the medial malleolus and the calcaneus. So what is inside the tunnel? The structures which pass through the tunnel include Tom, Dick, and Harry. It is the tibialis posterior, the flexor digitorum longus, the posterior tibial artery and the tibial nerve, and the flexor hallucis longus. We are interested in the tibial nerve, which lies between the posterior tibial artery and the flexor hallucis longus. Tarsal tunnel syndrome is a compression neuropathy caused by compression of the posterior tibial nerve within the tarsal tunnel. It is the most common compression neuropathy in the ankle and foot. Thickening of the flexor retinaculum may cause compression of the posterior tibial nerve. How about Baxter's nerve? The Baxter's nerve is the first branch of the lateral plantar nerve. The Baxter's nerve contributes to 20% of all heel pain cases, and this nerve provides motor innervation to the abductor digiti minimi muscle. When the nerve is affected by compression, the symptoms appear to look like plantar fasciitis. Involvement of the Baxter's nerve may affect running athletes, causing pain on the medial plantar aspect of the foot. Although entrapment of the Baxter's nerve may cause up to 20% of heel pain, this condition is usually overlooked. The Baxter's nerve can become entrapped within the medial heel. The entrapment will result in heel pain, paresthesia, abnormal sensation on the plantar aspect, which is the bottom of the heel, and medial heel tenderness. Two sites of entrapment are typical with Baxter's nerve impingement. First site located between the fascia of the abductor hallucis and the quadratus plantae muscle. The second site is where the nerve passes along the anterior aspect of the medial calcaneal tuberosity. On this diagram, you can see the typical two sites of entrapment of the Baxter's nerve. Calcaneal pin may cause injury to the posterior tibial nerve. The calcaneal pin may be necessary for traction or external fixation around the ankle. Usually, the transfixion pin goes from the medial side of the calcaneus to the lateral side of the calcaneus. The area around the calcaneus is surrounded by an important neurovascular bundle and several tendons. Error in placement or in the direction of the calcaneal pin can interfere with the neurovascular bundle. Avoid the bulged area in the ankle. It contains the neurovascular bundle. A safe, easy way to insert the pin into the calcaneus. Application of the calcaneal traction pin is done at the posteromedial site. There is a 3/4 distance between the palpable tip of the medial malleolus and the heel. The calcaneal transfixion pin is inserted in a transverse direction, as you can see here. Interdigital neuroma, Morton's neuroma, is a compressive neuropathy of the interdigital nerve. It occurs most commonly in the third interdigital space. Perineural fibrosis and entrapment of the interdigital nerve may be the cause of this problem. Thank you very much. I hope that was helpful.